let's get started then. All right, so go ahead, Paul. I'll let you. Thank you, everybody, for joining our educational lecture. Dr. Klimo is going to be the moderator today, and he'll go ahead and introduce the speakers today. So thank you for joining, everybody. I think you're on mute, Paul. You're still on mute, Paul. Should we unmute you? Let's see where you are.
Toba, it's near. If Paul cannot present, then I can help just in case he's. I think he has another Zoom at the same time.
Got it. Okay. All right. Well, then Dr. Nir Shimoni will be moderating today with Dr. Klimo, so his colleague. All right. Go ahead, Dr. Shimoni. Thank you so much.
Okay. Hello, everyone. I think we have a very nice session today with great people. We have Dr. Guillermo Aldavi from Texas Children, and we'll have our own people from St. Jude. We'll have Jason Chang that will talk about pathology, and Dr. Jorge Diaz that will talk about radiology, and all will be focusing about pineal region tumors. We'll talk about some imaging characteristics, and of course about what we're going to do with these kind of tumors. And then we'll have a session about 3 case presentations that we'll see later on. Do we have Dr. Aldavi on the line?
Yeah, I'm here, Dr. Shimoni.
Okay, do you want to start? I see that Klimo is on, but I don't know.
Sorry about that.
Hi, Paul.
Technical,
Want to say a few things?
Yeah, sorry about that. Welcome everyone to this session. Sorry, my thing just crapped out on me right when we were starting. Very excited to have everybody on board. This is a great topic, one of my favorite topics in all of pediatrics. It's rich with history and a lot of interesting pathology, a lot of really cool things to discuss in regards to the surgical management. We've got a great lineup of speakers. I thought we would actually start, if that's okay, with Jorge and Jason. So they're going to do an integrated talk. I asked them to present imaging and pathology. So they will kind of go back and forth with certain types of tumor. Obviously, we're not going to go through all of the types of tumors that you can find in the pineal region, but we'll hit kind of the main ones. And then I'll ask Guillermo and his fellow Neil to present some of the surgical aspects of managing these tough cases, these tumors. And then we'll have a number of speakers afterwards. Rabia will give a presentation on a case. If we get to it, Randy, our fellow, will as well. And then Kelly will also give a nice I asked her to give a nice historical presentation on Parinaud's syndrome, what it is and who Parinaud was. So I think we have about 90 minutes, but if we need to go over and if people are still interested, that would be fine, as long as we have good discussion. So if we can move with the first presentation, Jason and Jorge, that would be fantastic.
All right, excellent. Thank you. Thank you, Paul, for the presentation. As Paul was mentioning, this is going to be a combined presentation between radiology and pathology. I'll put the slides that are for both of us. They're combined, and I'll be starting the presentation, but then Dr. Chiang is going to be also tagging along. So I'm Dr. Lidias. I'm Associate Professor of Radiology at Le Bonheur Children's Hospital and at the University of Tennessee Health Science Center. I work with Paul and Nir every day, and it's a pleasure working with them. We have a lot of experience with tumors, and especially with pineal region tumors, there's a lot of casuistic in our hospital. We have the luxury to be related with St. Jude. There are many cases that are coming from St. Jude, and we have discussions together, but also we have also the luck to be able to have the pathology from St. Jude, and in this case, is Dr. Jason Chang is the one that's going to be representing them, and thanks to them is that we have a lot of good feedback, because these cases can be, as he's going to mention, very difficult sometimes to differentiate when it's a normal thing or it's a normal. Dr. Chiang, I don't know if you want to say something before I start the presentation.
Yes, thank you. Hi, this is Jason Chen. I'm a neuropathologist. I do brain tumors and brain tumors only. And I work with Dr. Paul Climo and Neil Shimani, just a few blocks away from the Bonner Hospital. And this is a very interesting topic, and thanks for the opportunity to speak today.
Okay. Excellent. So it was a great experience working with Dr. Chiang on this presentation. He has excellent things to say. So the first thing I want to point out is, what are the goals for this lecture? We don't want to talk about every single pineal region tumor, but we want to recognize the most common ones. We want to have an overview of the radiological characteristics, because they look very similar. Some of them cannot be even be differentiated on imaging, but what I will try to do is at least give you some point topics that make you lean towards one thing rather than the other one. We're going to have an overview of the microscopic characteristic of these pathologies with Dr. Chang. And at the end, we're trying to develop like a little system to have a differential diagnosis of what are we getting presented with every patient. So first of all, I want to talk about pineal cyst and pineal cytomas. And why is that? They're very, I'm putting them together because it's sometimes it's very difficult to tell if it's actually a pineocytoma or something else. This, you have 4 slices, the 2 on the left, up and down. They're one pathology, and on the right, up and down, that's a different pathology. So, and if we see the images, we're going to call it the same thing, right? It looks like it's just a prominent cyst. You have a CSF-like intensity. You have some areas of enhancement that it's okay to have in the pineal gland. So which one is which? So this one on the left, that's actually a pineal cyst. It's rather large, around 1 centimeter, and they have this area of enhancement that is posteriorly located, and it can be sometimes on the sides. It could be that there has a little bit of rim enhancement. So all those things can be normal. If you see some kind of a little more complex thing, let's say you have soft tissue, then you have cystic component, and then another area of peripheral enhancement, then make you think maybe something else, maybe a pineocytoma, maybe something a little worse. But on the right side, again, we're seeing the same thing. It looks like a cystic structure, but this one ended up being pineocytoma. So how we know this was a pineocytoma? This one was resected because it was causing mass effect over the tectal plate, causing narrowing of the ciliary aqueduct, and the patient ended up having hydrocephalus. That's why we got the pathology. The only thing that I want to mention before we go to the slices of pathology is that though these pineal region tumors, they are very dispersed in age. So you can see here 13 to 40, 20 to 40, 40 to 75. So basically you can have it during the whole life. So why I'm bringing this? Not because there's a specific time or age where one patient is going to get something or not, but just to give you an idea of what to put in the differential. So especially these two that are, especially in pediatric hospitals, what we see a lot, pineoblastoma and germinoma. When they are in children, we see them very young, around like 3 years of age, could be a little more, a bit less. When it's adults, it's between 20 and 40, but when it's in kids, it's around 3 years of age. Germinoma, most of them, 90% of the cases are going to be less than 20 years old, but we see them around like 11 years old, give or take. So this is important because you're going to see in the literature that germinomas are usually younger population compared to pineoblastoma, but that's not entirely true. It's true when we're talking about adults, and then 11-year-old for an adult, that's very young. But if we're talking adults in pineoblastoma, 20 to 40 years, yeah, it's older than this. But when the pineoblastoma presents on a kid, usually is very younger, less than 5 years old. So that's one thing I wanted to mention. The other point is that pineoblastoma, we see it a little bit more in females than in males. Opposite to germinoma, germinomas is for the pineal region, they are mainly males. Taking consideration, we are talking about pineal region. If we're talking about germinoma in general, if it's in the pituitary region, supracellular region, it's more common to have a female patient. So just to have this in mind. And then when we're talking more adult patients, for example, if we want to say about PPTID, it's going to have kind of the same amount of number of pathology. And pineoblastoma, we don't really know because sometimes they're just normal. We never take them out. For the main thing that if you're going to remember one thing about this lecture in radiology, is going to be about CTs. So in CT, you have a different distribution of calcification. So think about it like if it's a pineal region tumor, so it's coming from the pineal gland. The pineal gland is usually calcified, even if it's a pediatric patient, it's a little older, it's going to be calcified. So if you have a tumor growing from the pineal gland, that calcification is going to explode, right? Like a star, like this. Different if you have a germinoma. If you have a germinoma, it's not coming from the pineal gland, so that calcification is going to remain, but the tumor is going to grow around it, and see how you have that calcification, and then you have the tumor surrounding, right? Have it growing around. So remember that. Always get a CT with your pineal region tumors.
So here I just want to say that the challenge of diagnosing pineal region tumors from the pathologist's perspective, the challenges are usually twofold. Number one is because of its location, the specimen are usually very small, tiny biopsies. That's challenge number one. Number two is there is a really broad variety for the pineal region tumors. As you can see here, I listed the relatively more common pineal region tumors on the left side, include pineal parenchymal tumors, papillary tumors of the pineal region, or PDPR, a new entity called desmoplastic myxoid tumor of the pineal region, or germ cell tumors. But let's don't forget that there are other variety of the whole list of brain tumors that can happen in this region on the right-hand side. So in this part of the talk, we'll cover the tumor entities on the left-hand side, and also high-grade glioma and low-grade glioma. Next slide, please. And the classification for pineal parenchymal tumors has advanced a lot, as you may know, especially with the use of next-generation sequencing and DNA methylation profiling. So on your left-hand side, you can see that's a Disney plot of the DNA methylation profiles of a variety of pineal region tumors. DNA methylation has been a good tool for clinical use, and we can use the tumor's DNA methylation profile to tell us specifically what kind of tumor it is. And that has helped us to understand the pathology, the outcome, and also the molecular of those pineal parenchymal tumors. And on your right-hand side, you can see that the intrinsic pineal parenchymal tumors can be separated into 4 different varieties of pineoblastoma and also PPTID. And the age is important because the FOXR2 and the RB1 variant of pineoblastoma happens in the youngest patient, and PPTID, excuse me, is usually in the older patients. And the mRNA 1 and 2 pineoblastoma are associated with Dicer-1 syndrome. So germline is important. We need to look for other Dicer-1 syndrome associated tumors, pleuropulmonary blastoma, for example, Dicer-1 associated sarcoma, for example. And the RB1 tumor is associated with retinoblastoma. I still remember a case that we found a pineoblastoma in the RB1 group, and lo and behold, there are actually tumors in the eye by the MR that we initially missed. And the prognosis for the RB1 and FOXR2 pineoblastoma are very poor. And the PPTID is associated with a specific genetic alteration called KBTBD4. Which is very characteristic for this tumor entity. Next, please. And for the pineocytoma, remember, it is a very rare tumor type, and it is even rarer in the pediatric population. As you can see on your left-hand side, the pineocytoma has the very typical pineocytomatous rosette with multi-layer of tumor cells surrounding the neuropil-like core. And on your right-hand side, I want to show that that's the normal pineal gland with a lobulated structure without the pineocytomatous rosette. And because we don't take a normal pineal as a surgical specimen regularly, nobody wants to touch it if there's no problem with it. So even the neuropathologists are not familiar with the normal architecture of the pineal. So whenever I hear, oh, a pineocytoma in a pediatric patient, my number one question is it really a pineocytoma, or is it just a pineal gland that is misdiagnosed as pineocytoma? So that's actually the most important lesson here, making sure it's not a normal pineal gland. Next, please.
Okay, excellent. Now we're going to talk about pineoblastoma. As I was mentioned before, see that explosion of the calcification. You can see those little dots over here. Calcification because it's a parenchymal tumor, parenchyma of the gland is exploding, right? We have different sequences that we are going to use to evaluate our tumors. You have first the T1 pre-contrast, T1 hypointensity over here. This is a T1 post. You can see the enhancement of the lesion. This is a T2 flare image where the areas where they're cystic, they're actually not suppressed like CSF. They don't look dark like the CSF. They look a little hyper intense. We have the DWI and the ADC map. This is very important, and we're going to get into that a little later. And T2 is going to be a little hypo intense because it has a lot of cells. So usually have you're going to have lower T2 signal when you have an increased number of cellularity. And on the SWAN images, that's what is going to help us to see if there is some kind of iron or if it's any kind of calcification. So if this patient was, for example, previously biopsied or partially resected, you're going to see signal loss on sensitivity images. Or if there's calcifications, you can see them also over there too. For the evaluation of tumors, there are other sequences that we use at Le Bonheur quite often. One thing that can be used is this one. This is subtraction images. So you can see only the enhancing structures are showing. Basically, you are taking the post-contrast images and the pre-contrast images, and then from the post-contrast, you are taking all the pre-contrast, so you only see whatever is enhancing, and sometimes it can help to evaluate for little areas of metastases or for problems that are how the tumor is expanding. On the right superior, you have MRA. We like to use 3D time of flight MRA of the whole head. They are very thin slices images, so we can see exactly how these all the vessels and how they are moving around the tumor or within the tumor. It's important to have a pre-contrast and a post-contrast, because the pre-contrast, the way it is acquired, you are only showing the blood or the vessels that are going from the neck up. So you are only going to be seeing the vessels that are arteries that are feeding rather than the veins. So with the pre-contrast, you can see the arteries. With the post-contrast, you see both. But because you already know which one are arteries, then you know which one, the ones that are left are going to be veins, right? Like in this case. And then you can have something that is called Fiesta images that are very thin slices. I was talking before, the ADC map is very important. Why? Because if you have bright images on DWI and dark images on ADC, that's what we call restricted diffusion. So the molecules, in this case water, they are not moving freely because there are, for example, too many cells. Right? That's the case. Usually the higher grade or the higher, the more aggressive the tumor is, usually have the most cells, so you have a restricted diffusion that is more prominent. So the ADC map is going to be lower. So if you have a pineoblastoma, look at this value. It's about 800, minimum 353. That's very low. It makes you think that it's something like that. If it was a little higher, then I'll think about something less aggressive. In this one, I want to show you the T1 post-contrast on coronal images. See how we can identify the veins over here, and we can start evaluating to try to plan for the surgery, right? On the right side, we have a movie of MRA post-contrast. So we can see the vessels, we can see the interstitial veins, and then we can see how the vein on the left it's being completely surrounded by the tumor. So we can do reconstructions in coronal and sagittal, so we can see exactly what is the best approach to remove these tumors. This slide is just to show you how important is intraoperative MRI for these cases. As you know, intraoperative MRI is we bring the MRI into the operating room with the patient with the head open. We take the images and we try to evaluate if there is something that is residual or not. All these images have been taken in the operating room, so you can see, for example, the calvarium is open here, and this is the tract. And you can see in the movie how it was the tract that it was used for this case.
Okay, the pathology, the diagnosis of pineoblastoma is usually pretty straightforward if there's enough tissue. As you can see on the upper left-hand side panel, it's a small blue round cell tumor wall-to-wall with hypercellularity, lots of mitotic activity. You can see necrosis and apoptotic debris. And by immunohistochemistry, there's a wall-to-wall synaptophysin immunoreactivity. So it's usually pretty straightforward. And here I want to use the opportunity to introduce the pineal unlocked tumor. I think that's French, which is less well known, but it's an important variety of the pineoblastoma. The tumor will show melanocytic differentiation, as on the upper right-hand side, you can see the melanin granule within the tumor. And the tumor will show epithelial differentiation, as the lower left-hand side, you can see cytokeratin expression. And HMB45 will highlight the cells with melanocytic differentiation. And sometimes you can see even skeletal muscle differentiation as the Desmin stain on the lower right-hand side panel. Next, please.
Okay. Next tumor is a pineal parenchymal tumor of intermediate differentiation. I won't go over the images again because, as I said at the beginning, they look very similar. What I want to mention is that even if it's intermediate differentiation, you can see that there is already some kind of expansion and a little bit of infiltration into the thalamus. So those tumors can still be look infiltrative. Okay. What you want to pay attention is that ADC map always asks for the value of that. In this case, is 931, around 1,000 average. So it's higher compared to the pineoblastoma that is more aggressive.
And here's the pathology. The diagnosis of PBTID can be quite challenging. They don't look as embryonal because that's the upper left-hand side panel. You can see they have more cytoplasm. And again, they have wall-to-wall synaptophysin immunoreactivity because it's an intrinsic pineal parenchymal tumor. And they also have a neurofilament expression. The mitotic activity and Ki-67 proliferation index can be quite variable. Sometimes you see very high, maybe as high as the pineoblastoma, sometimes low as shown in this case here. And the grading criteria is not really perfect because it doesn't correlate with the outcome. You may see your pathologist trying to grade PBTID as grade 2 and grade 3, and sometimes struggling coding grade 2 or grade 3. Sometimes they may joking about grade 0.5. But it's really challenging to correlate that with the outcome. And the discovery of the KBTPD4 mutation is really important because it's really a feature of PBTID, not a pineoblastoma. So identifying this with sufficient sample by next generation sequencing is really helpful. Next slide, please.
Papillary tumor of pineal region. This is a very rare tumor. I want to show the images just so you know they look exactly the same. The ADC map is going to be on the lower side, a little more similar to pineoblastoma, but they can be variable. So there's no specific differentiation. Some people will tell you you can have some cystic components that make it more likely to be, but that's not true. You can have cystic component in any of them, especially if they're a little bit in the higher grade, because you can have a little bit of bleeding or necrosis. So there's not a significant differentiation on imaging.
And the pathology of papillary tumor of the pineal region, or PTPR, is challenging because oftentimes, because it's so rare, that pathologists forget about it. The key is you have to think about it when you look at a pineal region tumor. The tumor may be papillary as the upper 3 panels. You can see there's a vascular core with tumor cells surrounding it. Or it can look not so papillary as the lower bottom panel. And the key thing is to remember this in the differential and then do a cytokeratin stain. You will see a wall-to-wall cytokeratin stain, especially with Kim 0.5, and it's negative for synaptophysin. Next, please.
So finally, dermoplastic myxoid tumor. So again, this is from the literature. It's so rare, I didn't even have a case. But again, you see a pineal region mass, but it doesn't give you anything that is specific. You only know the difference because of the pathology.
And the pathology, desmoplastic myxoid tumor of the pineal region, it's a very rare tumor. And it's usually happening in adults, not in the pediatric population. So as you can see here, I have to steal the images from a publication. There are only probably less than 2,000 of cases reported together. The key thing to remember are two key things. One is remember that there is such an entity called the DMT of the pineal region. Number two, it's an INI1 or SMARCB1 deficient tumor. So not all INI1 or SMARCB1 deficient tumor are ATRTs. And this is a histologically low-grade tumors. We don't know the outcome. It may be better than ATRT, and it is not ATRT. So that's the key thing to remember. That's one reason I want to show this to everyone. Next slide, please.
Okay, for germinoma, again, remember the calcification. CT is so important surrounding the soft tissue that is the tumor. Calcification, this is a sagittal view, the tumor, and you can also see it on the SWAN images, as I mentioned before. You can see the calcification posteriorly. You have cystic component, but that's not specific. On the ADC map, all check it, cyst, average 829 is a little higher compared to the pineoblastoma, so that gives you a little more of the idea, but the age and the gender of the patient is going to be probably a little more helpful. If you have bifocal, it's a little easier, you know the diagnosis over there. And sometimes, I don't have a picture over here, but if you have like a heart-shaped appearance that's going to the thalamite bilaterally, that's something that is also, it has been related to diagnosis of germinoma rather than pineal parenchymal tumor.
And the pathology, usually the germinoma or germ cell tumors, the patient will come with a diagnosis. So the key thing is actually to make the diagnosis and to find if there are other non-germinomatous components. And one key pathology feature is actually not the tumor cells, but the background. You can see there's a loads of lymphocytes, the small lymphocytes. It's way, way more than the actual tumor cells. The tumor cells can be far in between, and you have to remember, once you see a very inflamed lesion, remember to hunt for the germinoma tumor cells. And if you cannot find or you are not confident, do a soft-4 stain or up to 3/4 stain. As the lower right two panels, you can see the tumor cells are actually far in between, buried inside the inflammatory background. So the key thing is, again, to remember to hunt for them. Next slide, please.
Okay, teratoma, like many of you know, it's very easy to identify the three layers. You can have fat, for example, here with very low density on CT. You have the soft tissue component, and you have the calcification. These kind of look like a tooth over there, right? On MRI is more difficult. You can still check it. If you have fat, you can do fat saturation images, and you can recognize if there is actually suppression, meaning there's fat in the tissue. You can see post-contrast enhancement of the soft tissue. But again, remember, if you have a pineal region tumor, always get a CT. That's going to be your ally.
And the pathology for teratoma or mixed germ cell tumors, usually the patient again come with a diagnosis. And for mature teratoma, you will see bones, cartilages, skin, GI, respiratory tract, epithelium. Sometimes you see tooth or eyes. And the important thing is to hunt for the immature component, like the lower left side panel. If you see an immature like neural tube, that's immature teratoma, or hunt for non-teratomatous, non-germinomatous component like the yolk sac tumor in the lower middle panel. And if you are not confident, FP stain or Glypican-3 stain would highlight the yolk sac tumor component. Next, please.
Okay, and finally, the last case that I want to show you is a midline glioma. As you can see, this is so difficult to differentiate from a purely pineal region tumor, but when we start scrolling down, we can see that this is actually coming from the brainstem. You can see the enhancement is a little different when compared to the other cases that were more complete. Everything was more was completely enhancing, but this one is kind of patchy. You have a little lower T2 signal because of the density, and the ADC is pretty low. It's about 600. If we want to see the CT, the calcification is not in a exploring pattern, and it's not in surrounding the calcification. So it's more, you have some calcification because the glioma can produce calcification, or maybe there was some kind of hemorrhage at some point and it become calcified.
So the pathology, high-grade glioma and also low-grade glioma can happen in the pineal region, and it's usually, as Dr. Lee said, it's invading from other areas and involve the pineal region secondarily. The upper three panel, you can see it was called glioblastoma multiforme. It's called multiforme because it looks really different from tumor to tumor, and also different from the embryonal tumor because they usually have more cytoplasm. The glial processes, the pink processes, usually will tell you this is a glioma, not an embryonal tumor. And we have immunohistochemistry or next generation sequencing to molecularly characterize this tumor. For example, p53 IHC highlight the p53 mutant tumors. histone H3 K20M stain will tell you, oh, this is the K27M mutant of diffuse midline glioma, and there's ATRX loss. The tumor cells are actually blue, not brown. It's hiding in the background. It will tell you that this is the ATRX lost high-grade glioma. Next, please.
Okay. So finally, the take-home points on radiology is always get a CT. The tumors, if the tumor is coming from the pineal gland, there's going to be this exploding configuration. And if it's coming from another area, it's just going to surround the pineal gland. Check the age and the gender to help you with the differential diagnosis, and always check the ADC map. Ask for the ADC value, so you can evaluate if it's really low. Maybe you are dealing with a pineoblastoma, but take other things in consideration.
And the take-home message from a pathologist is that please give us more tissue if that can be safely done, because there is really a diverse variety of pineal region tumors. We will try to give you a diagnosis, but we have to consider the differential diagnosis. And nowadays, we need tissue for immunohistochemistry, NGS, methylation, all need tissue. So please, more tissue if that can be possibly safely done. Thank you.
Thank you very much. This is my email, and if you have any questions, or later on we can take questions for.
Jason, Jorge, that was fantastic. Any questions while we transition over to the next speaker? Does anybody out there have questions? Either chime in or put it on the chat box. Okay, well, I think we'll move over to Guillermo and Neil for the surgical considerations. We do have one question. Any thoughts on liquid biopsies? Jason, do you want to?
Yes, I think that's the next front, and various institutions are developing that. At St. Jude, we are developing that as well. It's more useful for tumors they like to shed into the CSF, for example, metroblastomas, or other inguinal tumors, and pineoblastoma maybe, but we have less experience with that. The false positive rate and false negative rate, and also the technology involved. Those are usually the barriers that I think everyone's trying to resolve that, overcome that, because as a research paper, you can show people beautifully that, yes, it can work. But as a clinical utility for patient care, it cannot be just, oh, it can work. It has to work in positive way and negative way. When it's positive, it has to be really confidently positive. And when it's negative, it has to be really confidently negative. So those are the barriers so far. But I think the technology is improving. I think eventually we'll get there.
And I will just echo Jason's last point is in terms of tissue, it's really important to get a good sample of tissue. And that's why if I have to do a biopsy of a pineal region, I tend to do it open because of all the testing that is needed. Needle biopsy, I think from a technical and safety standpoint, has some challenges. So again, if you need tissue, give them plenty because there is such a wide variety of different pathologies and the testing that is needed to give you the accurate diagnosis. I know, always more tissue, always more tissue. I hear it every week. All right, any other questions while we get Texas Children's folks on? All right, thank you, Jorge. Thank you, Jason. Very much appreciate all your hard work. Thank you, thank you, thank you. All right, Guillermo and Neil, you guys have your talk ready to go?
Yeah.
Wonderful.
Thanks, everyone. That was wonderful. Really appreciate Doctors Lee and Jiang talking about the nuances of that. Going to kind of take it a step back here, and how do we get to the point of actually having tissue? How do we get to the point of actually having imaging to work with? How are these patients presenting, and what do you need to do when you're first seeing them, as well as how do we surgically manage them? Dr. Aldave and myself, I'm Neil Laxpati, I'm the Texas Children's Fellow. We're going to be talking about that. So, all right. So, in terms of what we're going to speak about, I'm going to start with the initial management, including dealing with the symptoms that bring the patients to the hospital, how we go about getting a diagnosis, the role of biopsies here at Texas Children's, and how the kind of workflow that we think of here. Dr. Aldave will kind of go into some of the nuances of second look therapy and neoadjuvant therapies, and then we'll go through some various surgical approaches, of which there are many to the region for section. So in terms of the initial management, you're on call, you get a call from the ED about a patient, and usually they will have a CT scan that tells you about they have some sort of pineal mass. And just to kind of review the important thing, this is a great radiology talk, but the important thing about the pineal region is that there's a lot of things around it. It's in the center of the brain. It's difficult to get to, but it's also surrounding a lot of very important structures. So just kind of thinking about the anatomical boundaries that you're dealing with, you have, the posterior wall of the third ventricle forming one, the splenium, the corpus callosum forming another, the thalami on either side, and it projects inferiorly into the quadrigeminal cistern. Also in the same region, you're looking at some pretty complex venous anatomy, the vein of Galen, inferior cerebral veins, basal veins, that sort of thing. And so the symptoms that are going to present deal with the expansion of this tumor into the tissues around it, pressing on it, potentially invading it. That's what's going to bring these patients to the hospital. And so one of the things you see with a lot of these patients are headaches and hydrocephalus as a result of aqueductal stenosis. And so the initial thing that will probably bring them in, particularly these kids, is going to be headaches, nausea, vomiting, that sort of thing. Parinaud syndrome, I won't go into it because we're going to hear a great talk about that in a little bit, but you may also see some hypothalamic syndromes, diabetes, or slowed growth or precocious puberty as a result of these tumors pushing on the structures around them. So since hydrocephalus is one of the first things that you're going to see, the question is, what do we need to do about it? It really depends on whether or not this hydrocephalus is acute. Is the patient decompensating? Do we need to do something more urgently or emergently for them? Or can we hold off? Can we kind of put together a picture, maybe get some additional imaging, that sort of thing? So really your first decision point in the middle of the night is whether or not the patient needs an EVD. This is a quick and easy fix for the hydrocephalus. Allows you to get some CSF for potential sampling, and is usually sufficient to treat the patient's acute decompensation. If you have more of a chronic hydrocephalus picture, or you may be able to defer an intervention initially for a potential endoscopic third ventriculostomy, which we'll talk about a little bit later. And then there is a role for longer-term CSF diversion with ventriculoperitoneal shunts, although that's usually not your initial sort of strategy. And then finally, resection itself can treat the hydrocephalus. It's a mechanical compressive problem. Removing the tumor may be sufficient to restore normal cerebrospinal fluid drainage. Once you've kind of stabilized the patient and are starting to make your assessment, the question is, what is it? As Dr. Lee was kind of pointing out, a lot of these tumors look the same. So imaging can be very useful, but it might not be definitive. It usually isn't definitive. And so we need to kind of figure out what we're dealing with. Our practice is to send serum biomarkers regardless of whether or not we have access to cerebrospinal fluid, and to make our decisions based off of that. We send alpha-fetoprotein and beta human chorionic gonadotropin. We don't have much experience with placental alkaline phosphatase, even though it shows up in the the boards chart. But and we have good experience with working with those. If we basically split these tumors up into 3 categories based on their serum biomarkers. If they're negative, then we're going for a biopsy because we need to figure out what this tumor is and how best to treat it. And the treatment depends a fair bit on what it is. If they're positive and we consider greater than 80 to be positive, then we don't see a great role for biopsy because we've been able to do so. We've been able to diagnose it based off of the serum biomarkers. There's this region of mildly positive where it's not quite enough that we're convinced. There may be mimickers that are going on that really tends to push us into the biopsy realm as well, again, for a definitive diagnosis. If we have cerebrospinal fluid, we'll send that as well for biomarkers. But in our practice, if it's high in the serum, it's going to be even higher in the cerebrospinal fluid. And so usually what will end up happening is if it's fluoridly positive, then we'll know it based off serum. If it's not fluoridly positive, then we're heading towards a biopsy regardless. Dr. Klimo kind of alluded to a couple of the different methods of biopsy. We can approach this region stereotactically, which reportedly has a low rate of complication, although I think that is based a lot of there's a fair bit of selection bias, people not reporting their bad outcomes, as well as certain particular tumors in their anatomy potentially being of a higher yield or more likely to have a good outcome from a stereotactic biopsy. The other concern from a stereotactic biopsy is what Dr. Chiang was talking about. You don't get a lot of tissue. So you may underdetect heterogeneous tumors. You may not have enough tissue for all the molecular analysis. And there tend to be higher risk of hemorrhage, and particularly hemorrhage that you can't control, which can be very dangerous in this portion of the brain. Endoscopic biopsy is another option. This is pretty commonly performed, and it can be coupled with an endoscopic third ventriculostomy. So if your patient either already had an EVD or was able to hold off on an EVD, you could perform an endoscopic third ventriculostomy and then follow that up by biopsying the tissue by reaching back into the third ventricle and grabbing some. That does allow you the opportunity to treat any hemorrhage at the site with coagulation. You still are dealing with small tissue samples, so there is the risk of underdiagnosis or misdiagnosis. And it's very important to also, in terms of the planning for this, to do the endoscopic third ventriculostomy before the biopsy. Tumors bleed, and if you have a cerebrospinal fluid that's completely filled with blood, ventricles filled with blood, you won't be able to perform that third ventriculostomy. And finally, as Dr. Klimo mentioned, you can perform an open biopsy or an open resection. This does yield the highest amount of tissue, but does come with it the associated surgical risks. Once you've gotten through the initial sort of management to the point of definitive treatment, now we can start to figure out, once we've diagnosed what we have, we can figure out what we need to do about it. So in general, what we do is we treat our germinomas and our non-germinomatous germ cell tumors, radiation and chemotherapy. Again, this can be based off of our biopsies or based off of our serum biomarkers. We do perform second look surgeries for NGGCT as needed. And Dr. Aldave will go that a bit further. Most of our pineal tumors, the parenchymal tumors, pineocytomas, and so forth, are treated with risk of maximal safe resection. And so, based off of those biopsies and those initial serum biomarkers can be very important for helping distinguish all of this. So just kind of to recap, your first steps in treating these patients is to figure out how to stabilize them first and whether or not they have hydrocephalus that might be life-threatening, which involves placement of an EVD. If they're more stable, you can start to put together a treatment plan in terms of determining what this tumor is and coupling CSF diversion with either an ETB or a shunt with some sort of biopsy. accessing the ventricle does give you CSF for analysis, but we don't necessarily find that as useful in our practice. The biopsies themselves, again, we can diagnose based off of CM biomarkers if they're sufficiently positive to really hit that threshold. If not, then we're going to have to look at each patient on a case-by-case basis to determine what's the best treatment for them, best biopsy for them, the safest and most likely to get a diagnosis. And then based off of those results, we can then move into the definitive treatment stage where we start to decide whether or not patients need maximal surgical resection, radiation, chemotherapy, or some combination of them all. All right, Dr. Aldavi, I'll turn it over to you.
Okay. Thank you, Neil. Okay. No, this is not the display I want. Sorry, guys, give me 1 second. Okay, got it. Thank you. I want to spend 5 seconds thanking, of course, Dr. Primo for the invitation, Dr. Niazzi, and Dr. Leonard. I think it's an honor being here. And indeed, we are gonna I'm gonna talk briefly about second look surgery for germ cell tumors. Second look surgery refers to the surgery we perform on the potential residual left after treatment with chemotherapy, and this applies mainly for germ cell tumors, where the first step of treatment is germ cell tumors. So basically, when we are dealing with germ cell tumors after the standard of care, which is usually first 6 cycles of chemotherapy, we may find 3 different scenarios. If we have a complete response, great. The patient can move forward with craniosspinal radiation. If the tumor is bigger, despite the negative markers, probably we are dealing with a classic growing teratoma syndrome. Is the teratoma component of the tumor that is growing, and radiation is not going to do anything with it. So I think the role of resection is cleared with no question. The controversy may come with we have a partial response, non-germinative germ cell tumors that has a 50% reduction in size. So what do we do with the rest? So if we go by the last recommendations, the SNO and the European also Association of Neuro-Oncology are recommending surgery for any residual left after the 6 cycles of chemotherapy for germ cell tumors, basically, with the argument that we have up to 70% chances of finding a viable tumor, whether it's a residual non-germinative germ cell tumors or teratoma, and therefore it can improve the survival of these patients. It's true that in up to 23%, and you can see the percentages are very variable and depends on the series you pick, you may only find necrosis or fibrosis. But usually the recommendation is to move forward with surgery if there's a residual left after chemotherapy before we do radiation. What do we know about neoadjuvant therapy for pineoblastomas? Well, at TCH we don't do it routinely, even though we can get amazing responses. Like this 2-year-old with pineoblastoma, after 2 cycles of chemotherapy, we got an amazing response. And of course, the surgery that we did after the second cycle through a transtentorial approach, it was much easier and therefore safer for the patient. But the truth is, at least in our experience, that we find a great variability in the response. We have patients with tumors that have an amazing response, where others, basically, the tumor doesn't change, at least on MRI. So what do we do? Well, we assess on a case-by-case basis, usually really big tumors in young kids, infants, and toddlers, with contrast enhancement or avid contrast enhancement that is especially, and they are especially encased in some of the main arteries. In this occasion will be the PCA or the SCA. We try chemotherapy first. And I'm saying the contrast enhancement because in our experience, and not just for pineal tumors, but for any type of a small blue round cell tumor, the responses that provide a reduction in tumor volume are in those tumors that have an avid contrast enhancement. So questions that may come up with neoadjuvant chemo for pineoblastomas. Well, what are the potential benefits? Does the chemo decrease the blood loss? It seems like it does, even though this is coming from the experience of surgeons. So it's pretty subjective, and I think we have to take the statement with caution because it's really hard to know what does it mean, especially if we don't know what we are comparing with, right? But another potential benefit that I don't know, that we may think is that it may decrease the risk of dissemination of the tumor if you do chemotherapy first. We don't know that. On the other side concerns is that does it increase the risk of infection? Because usually these chemotherapies are myelosuppressive, and therefore the patient may be more fragile for surgery after the second cycle compared to how it was a diagnosis. Usually in the series, in our experience, it does not increase the risk of infection. We haven't seen any complication from that, and I'm sure Paul can comment on that, since I think they do neoadjuvant chemo on almost all the patients with pineoblastomas. Another question, is it always feasible? Usually, or sometimes we face really big tumors that may have some mass effect in the brainstem, and we may be slightly nervous about doing chemo without surgery. But the truth is that most of the patients are diagnosed based on the hydrocephalus. Once you address the hydrocephalus, I think it's, in our experience, it's totally fine to do a neoadjuvant chemo without surgery up front. And finally, surgical approaches to the pineal region, which I'm sure you all know. We have the three main options: the intrahemispheric transcallosal, intravenous or paravenous, with different variations. We can approach the pineal region from more frontal, parietal, or even occipital or parieto-occipital through the splenium of the corpus callosum. Anyway, you have to do a transcallosal approach and access the velum interpositum between the veins, or leaving the veins outside, the occipital interhemispheric transtentorial, and of course the infratentorial supracerebellar. And this is my personal opinion. I think all three approaches are suitable for most of the tumors. So I'm sure you can get most of the pineal tumors out with any of the three options, but it's true that there are a few anatomic considerations that I think is worth keeping in mind when we are trying to choose the right approach. There is an issue from neurosurgery focus video from 2021 that is basically dedicated to the pineal region tumors. You have 20 videos there that I think they illustrate very well different options we have. In fact, the first one I'm going to show is one of them. So what are the anatomic considerations that, at least in our experience, we keep in mind? Well, tumors that cross the plane of the ICVs, or they are above the plane of the ICVs, I prefer to approach from an intrahemispheric transcallosal approach. I'm not comfortable going through the plane of the ICVs from a supracerebellar or a transtentorial approach. I think it's riskier than a purely intrahemispheric transcallosal approach. So it's one thing to consider. Tumors that are within the aqueduct, I think the view that you get from an intrahemispheric transcallosal approach is superior. You can see the whole aqueduct from the top, whereas from the back, it's harder to do. You can make an argument like this, for example. Sometimes this is a pineoblastoma we did for a supracerebellar approach. The tumor, and this is 5 years ago, probably today we'll have done a transtentorial approach or an intrahemispheric approach. Sometimes it's true that the tumor within the aqueduct can come with the rest of the mass, but you don't know that, and at least you take a risk that you may leave some tumor behind in the aqueduct through a posterior approach. So usually, at least nowadays, I try to approach these tumors from the top. Okay. And finally, of course, occipital intrahemispheric transtentorial approach. I think this is usually my preference for a standard pineal tumor like this 6-month-old girl who had a pineoblastoma. But I think it's by far, and at least in my opinion, the best option to reach tumors are extending down into the fourth ventricle, or pushing the fourth ventricle, because the angle is just I don't know how you can get it through a supracerebellar, and it's a very long reach to access or approach from the top. And so finally, I think better than describe how we do it, I think is showing it with videos. This is a 15-year-old with a pineoblastoma. We did a diagnosis through a flexible endoscopic biopsy with ATVs at the same time. And I think this is a classic tumor approach. You can reach through any of the three options. In this case, I was maybe worried about the left ICB. There's a vein of Gillen that was going pretty down, and the ICBs, they had a pretty stiff angle. So anyway, we decided to do it through an intrahemispheric transcausal approach. In this, in my experience, I mean, it doesn't matter, but we place the patients with the right side, or at least the side you approach the tumor down, so the hemisphere falls, and you don't have to use retractors. But a neutral position is absolutely fine too. And this is the video. You can see. Let's see. I'm displaying. 1 second. Let's see. Okay, 1 second. For some reason, I think I'm going to need to display this in this view. It's not ideal. Okay, well, I'm sorry, but this is, I think we can see the video. This is an intrahemispheric dissection, chiasotomy. We only place the retractor to hold the pulse a little bit. At the beginning, we fall into the left lateral ventricle. I think it's key in this approach to find both lateral ventricles to make sure that we are in the midline. We don't have to worry about the fornix that much. If we are very posterior, we have to remember the body of the fornix leave the body to keep the curves of the fornix that goes along the anterior wall of the atrium. So as long as we stay behind the anterior wall of the atrium, the fornices, it should be safe. We are they're opening, exposing the arachnoid of the velum interpositum. We can see the choroidal artery. It's a branch of the posterior lateral choroidal artery, the branch of the PCA that we have to coagulate. We are very careful on the opening of the arachnoid, basically because sometimes the arachnoid of the velum can be so thick that we don't see the ICVs. But hopefully, well, in most of the cases, there is a cavum of the velum, especially in the posterior part of the third ventricle. So in that region, the ICVs are mildly separated, so it's safe if you open the arachnoid right in the middle, which is what we're doing. The arachnoid can be mildly thicker than usual from the tumor, not in this case because it's a small tumor, but we are opening the arachnoid, and we can see the classic component of view of the pineoblastoma, moderately vascular, very soft at the beginning, and we can see that white structure there. It's the avenular commissure. It's very hard to see an avenular commissure in a pineoblastoma. Usually it's gone by the time we make a diagnosis, but in this small tumor, we can see it. So we're taking a specimen for a permanent because we have already diagnosis. We're exposing the third ventricle. That's the posterior commissure, as you can see there. And that's a nice view of both commissures that we have. The avenular commissure on top of the pineal gland and the posterior commissure on top of the tectum and below the pineal gland. We're moving forward with the dissection on the other side of the avenular commissure, and we're going to expose the aqueduct. And this is a view that we don't get if we come from the back. We're working between both ICBs. The window is not very large, but it's more than enough to follow the principles of microsurgery. So that's the aqueduct. We protect the aqueduct, of course, with a small, tiny cottonoid to prevent the blood from getting into the fourth ventricle. And this is the final That's the final part of the final piece of the tumor that's attached is expected to the left ICB. You would expect in a small tumor that it's going to have a nice plane. It's not always, at least in my experience. And we don't take any risk. We basically leave a small, tiny piece of tumor behind, which you don't even see on the MRI. We coagulate it. And this is the final view with the aqueduct, the right ICB, the left ICB, posterior commission on the aqueduct from the top. And you can see how both ICBs are split there. The nice thing about this approach is you don't touch the cerebellum at all. The kid went home within 48 hours. And yeah, and in the post-op MRI, you cannot even see the residual left on the left ICB. Moving forward, the next approach, it's the occipital interhemispheric transtentorial. This is, you can make an argument, this is not a pineal tumor, and it's true, but it's a tumor coming from the superior part of the vermis. It's a small round blue cell tumor, and is pushing. You can see a small component in the coronal is reaching the ICBs, and I think to prove the concept that this is a very valid approach for tumors that extend down to the fourth, it's good. So this is a surgical video. This is so usually the occipital interhemispheric, we do a classic occipital craniotomy. We put the boreholes over the sinus. We don't need to expose the torcula. We don't expose the torcula with the craniotomy, but we expose the sagittal sinus to maximize the exposure that the sinus, the dura is going to keep us. So this is anterior, and this is superior, this is inferior. So this is the right occipital lobe, and we have the dura reflected towards the midline where the sagittal sinus is. The first thing we do, the brain is very relaxed because of the EVD, is to identify the transverse sinus, torcula, splenium of corpus callosum there, and straight sinus. And that's the arachnoid of the vein of Galen. That's a venous lake that is pretty common in infants. This kid is 2 years old, but it doesn't prevent you from doing this approach. We open with an arachnoid knife first, the tentorium. We make sure we grab the full thickness before we move forward with the opening and the coagulation. And we extend the opening, of course, all the way down to the edge of the tentorium, about 1.5 centimeters far from the straight sinus. As you can see there, we put a couple of sutures to suspend the tentorium, and we put 2 big cottonoids that are going to protect the straight sinus from the heat from the microscope that could cause thrombosis or something like that. So, and this is the feel. First, we dissect the arachnoid. The arachnoid is pretty thick, and it happens in the velum interpositum. Sometimes you don't see the veins, so you have to be careful in the initial dissection. But it's a very nice dissection once you find the right plane and you see the veins. And the advantage of this approach over is that you can get access to the vascular supply probably sooner than through a supracerebellar approach. You get access to the SCA or PCA branches right at the beginning. You can see both ICVs and vein of Galen on top with a very nice arachnoid plane, and probably because this is not technically a pineoblastoma. And we follow, again, the same principles of microsurgery. We circumferential dissection, but we take care of the branches, the vascular supply from PCA or SCA before we do a debulking, especially in tumors that are affirmed. And you can see there the fourth nerve in the ambient cistern. So if we're following the tumor from superior to inferior for the right side, this is the inferior border. We can be slightly more aggressive. We have a nice plane all around with the cerebellum. With the brainstem, we are much more careful, of course. But once we find the plane, we marked with cottonoid that also protects the normal tissue. We try to do a debulking. It's a firm tumor, as it usually happens. And you can say, well, maybe with this approach, you may not reach the contralateral side, but we do. It has never been an issue. And we're working on the left side of the patient, left side of the tumor through our right transtentorial approach. We're peeling here the tumor from the brainstem, and you will see. in a second. We're going to expose the fourth ventricle. The opening in the fourth is very small, so I don't think an access the tumor through the fourth ventricle will be a good idea in this case. And we of course protect the fourth, and this is the final piece. Once we have the tumor all surrounded, we make sure it's released from the brainstem, and you can peel. You can bring the tumor almost in block. I mean, of course, we have been working with debulking first. And this is the final view with the fourth ventricle. That's a PCA branch and ambient cistern. This is the occipital lobe, the cerebellum. This is the view usually we get after the resection. That's the opening of the tentorium, and we don't put anything there. And that's the occipital lobe that is relaxed, because usually these kids, they have, of course, the hydrocephalus. The ventricles are big, so just an EVD gives you a lot of relaxation. And this is. Yes, this is the, no. Well, this is the final, this is a post-op MRI that shows a complete resection with no complications. And that's it. Neil, I think it's your turn.
All right. So the last approach that we'll occasionally do is the infratentorial supracerebellar. There are, two general ways of positioning the patient for this. We tend to do this prone, maybe with a head flexed or along those lines. There are institutions where you'll do it sitting. It really depends on your anesthesiologist. I've never actually worked at a place where the anesthesiologist felt that comfortable with the sitting position. So it just depends on where you are. I think there are definite advantages to doing it in a sitting position. In terms of drainage and in terms of relaxation of the cerebellum, potentially, though, at the expense of more difficulty with your arms and positioning. So in the supracerebellar infratentorial approach, just to kind of orient you, on the left side is superior and the right side is inferior. This is the cerebellum here. We've already done our suboccipital craniectomy, moved our way up, all the way up to the torcula, and elevated that so as to get as much as possible along the tentorium. We start, there's these superior cerebellar veins, vermilion veins, that can be taken pretty readily. And you'll have to, in order to get enough relaxation to bring down the cerebellum. Usually the EVD we have in place in these cases is draining at this time also to provide some relaxation. You don't have to take every single vein. In fact, you want to try and avoid doing that. And so depending on where those veins are and how you're trying to get in, we will try and preserve as many as we can. Like Dr. Aldavi was saying, oftentimes the arachnoid here can be very thick. And so you have to kind of carefully work your way through because you will come across various large venous structures in your dissection. Blunt dissection is quite useful, bipolars and micro pickups are quite good at working this tissue. This ball dissector is also very good at kind of breaking through this kind of thick arachnoid adhesion. You can start to see that some of these venous structures are starting coming into view. We've got this tentorium superior to us, and now we're starting to expose the various different basal veins and pineal veins and inferior cerebellar veins, as well as the vein of Galen. And really, you want to spend a fair bit of time clearing up all this arachnoid, getting these adhesions controlled. If you don't, then while you're trying to dissect the tumor, you may tug on something and inadvertently cause a rupture, and then you're hunting for the bleeder. Here's the tumor here, and we spent a lot of time kind of trying to work our way around it to expose it and see if we can get our way with not taking that vein. Unfortunately, there wasn't a way to do that. As we get deeper, you start to think more and more about whether or not these veins are actually important, and so no vein can be taken with impunity, but you often do have some fail-safes here. Similarly, we dissect circumferentially. We try and maintain this was a particularly cystic mass, and so working through it, we try to preserve the borders as much as possible. Eventually, once we got kind of stuck, we drained it. And then as we start to use some gentle traction, countertraction to kind of separate it off of the splenium it was growing from, and separate it out from all the surrounding tissue. And then we can remove it in total. Right. I saw there were a couple of questions in the chat, Dr. Aldave.
Yeah.
So the first one was like, how does hydrocephalus affect the approach you take, or an EVD pre-op? I could say that in my experience, a lot of these patients have EVDs, even the ones who get endoscopic third ventriculostomies. That EVD, if they have a successful EVD, my experience has been that we will clamp that EVD and keep it in place to potentially work as a drain post resection to make sure that or to have a pop-off valve in case the ETP doesn't take. And that can be useful also for helping getting some relaxation during the surgery. And maybe Dr. Aldave can talk a little bit more about that too, in terms of the approaches.
No, yeah, Neil, even if they don't have an EVD pre-op, the first thing we do in surgery is to place an EVD, and by the time you have to do the intradural dissection, the brain is already relaxed. So it always helps, no matter what approach you take, especially if it's a supratentorial approach. But it's totally fine if you do it at the same time. But I will always start with an EVD. And the other question is, why expose both lateral ventricles when you can directly open the velum interpositum and view the internal cerebral veins? True, you don't have to expose both lateral ventricles. If the cavum is big enough and you can navigate it within the cavum without opening, that's totally fine. The thing is that here I fell into the left lateral ventricle, not on purpose. So if that happens, you have to make sure that you are where you think you are in the left lateral ventricle and not in the cavum. You may think that you are in the cavum, but you're actually in the left lateral ventricle, or you may think you're in the right, but you are actually in the left. That's why if I have any doubt of where I am, I try to find the other ventricle and to make sure that I am in the middle line, because sometimes the things are not that evident. And sometimes you don't see even when you open the velum, you don't see the veins because the arachnoid is taken off. So yeah, you don't have to open both lateral or expose both lateral ventricles if you are 100% sure you are in the velum, in the cavum, as you should be. Paul, I have a question for you, because I think is a reason for controversy is, what do you do with a pineal tumor that has, like, let's say, several markers of an ACG of 40, 50? Because I know there are places that they assume is a germ cell tumor or a non-germinal germ cell tumor, and they move forward with chemotherapy, with biopsy. Here at TCH, we do a biopsy, but where you set the mark, whether you need a biopsy or not, I think is kind of arbitrary. And I don't know. I was wondering, what's your experience at St. Jude? What do you do with the mild elevation of the markers? Do you do biopsy, or do you move forward with chemo? Or
I would say for pineal region tumor, if we had any elevation in the markers, I'm almost positive that we would just go right to treatment. I don't think we would do a biopsy. We would do the treatment, see how the markers respond to treatment. If they normalize, then obviously we're looking for, the growing teratoma syndrome. So for those, even if it's slightly above normal, I think that would be enough for them to just pull the trigger and treat without tissue.
Yeah, our discussion with oncology is yeah, I mean, we know if the markers are positive, it's a germ cell tumor, no question. The problem is a germinoma or is a non-germinomatous germ cell tumor, because the treatment is different, right? I mean, non-germinomatous germ cell tumor carries 6 cycles of chemo and CSI.
Yep.
As a single, right, pineal germinoma, you can get away with just ventricular field radiation. And anyway, it's a distinction. And I don't think there's a clear cut. And I think that our management is kind of arbitrary when we set the limit of when we are comfortable with moving forward with treatment. And Dr. Niazzi is asking if we use navigation. Yes, I think it's very helpful, especially to set the chiasotomy where you want it. Yeah, once you're in the ventricle, I think the navigation is not that helpful. But I think for the chiasotomy is key, especially if you're doing a intrahemispheric transchiasm. So for the rest, I think you can, for a transcendental approach or a supracerebellar, I think you don't need it, since I think the anatomy is pretty clear.
I'll just make a couple of quick comments, if I may, on the first 2 questions. So with regards to the hydrocephalus, I totally agree. I think for the the parietal, interhemispheric, transcallosal, and for the occipital, those supratentorial approaches, CSF diversion really helps the dissection, really helps. And so I've always felt that a shunt relaxes the brain much better than a third ventriculostomy. So those kids that have a third ventriculostomy, yes, their hydrocephalus may be controlled, but when you go to do their interhemispheric dissection, the brain is still full. So for those patients, I tend to leave Ommaya reservoirs for all my ETVs. So for those patients, I'll do, a good 30, 40 cc tap of the Ommaya prior to positioning, and always have the Ommaya reservoir in the field so that I can tap it if needed. That kind of prevents, or, hopefully I don't have to put an EVD in those patients. When you're going prone for the occipital interhemispheric, again, if that kid is living off an ETV, it just may not be quite good enough in terms of the relaxation for the interhemispheric. So for those, again, tapping the Ommaya or having a parietal burr hole ready to go for an EVD is very helpful, because the interhemispheric dissection on a full brain, especially if it's either in the parietal where you're retracting on the motor strip or premotor, you're retracting on the occipital lobe, it's just not very fun. So in the interest of time, it's looking like 7:30 here, my time, 8:30 probably on East Coast. We'll shift to the next talk. Kelly will give us a brief talk on Parinaud and who he was and what is Parinaud syndrome.
All right, thank you so much, everyone. Let me just get my slides in presenter mode here. Can everyone see my slides okay?
Yep.
All right. Good evening, everyone. My name is Kelly Chamberlain. I'm a PGY6 resident at University of North Carolina, UNC. It's a great privilege to join you all tonight. I'm just going to give a brief talk, 10 minutes or less, on Parinaud syndrome and a little historical background. All right, so as you all may know, the classic triad of Parinaud syndrome consists of upgaze palsy, convergence retraction nystagmus, and pupillary hyperreflexia. So the convergence retraction nystagmus is irregular, jerky nystagmus combining convergence and retraction of the eye into the orbit, especially when the patient's attempting upgaze. There are many etiologies of Parinaud's. We're talking today about pineal region tumors, so that is relevant, but there are also etiologies suggestive of like midbrain infarctions, midbrain hemorrhage, multiple sclerosis, encephalitis, vascular abnormalities such as AVMs. You can have it from infection, trauma, obstructive hydrocephalus, as well as sometimes tonic-clonic seizures can cause Parinaud. Figure 1 here is a photograph from a patient of Harvey Cushing's who had Parinaud syndrome and unfortunately died before a diagnosis could be made. but the autopsy specimen demonstrated that there was a tumor located in the pineal region, which you can see here. There are various other names for Parinaud syndrome, which are listed here, but I think the most common used is Parinaud's. So for epidemiology, it's sporadic. The most common cause is pineal gland tumors or midbrain infarctions, and up to 65% of cases are due to primary midbrain lesions such as tumors, strokes, or hemorrhages. And then the classic triad is actually seen in the majority of the patients. 65% of the patients will actually present with this classic triad. In terms of pathophysiology, the signs and symptoms are caused by compression of the rostral midbrain and pretectum at the level of the superior colliculus, and the involvement of the vertical gaze centers, which are in proximity to the superior colliculus, result in this condition. There are some patients that may present with lid retraction in the primary position, which is called Collier's sign, and I have photos of that to show as well. And the cause is thought to be due to damage of the levator inhibitory fibers at the posterior commissure. Here are some photos showing Parinaud's syndrome as well as Collier's sign. And I just keep reiterating the classic triad there. But you can have other symptoms such as diplopia, which is very common, blurred near vision, loss of convergence can be seen. And then you can have conjugate down gaze in the primary position, which we call the setting sun sign. So who was Parinaud? So this condition is named after the French ophthalmologist and neurologist Henri Parinaud. He lived from 1844 to 1905. He described a series of patients with these symptoms and tried to study the causative mechanisms. And he is considered like a pioneer of the practice of neuro-ophthalmology. Some other interesting facts about him is that he, in medical school, he studied optic neuritis in children with meningitis. And another condition named after him is Parinaud's oculoglandular syndrome, which is consisting of fever, papillary conjunctivitis, and lymphadenopathy, which is a rare manifestation of cat scratch disease. So he has another eponym as well. So just to reiterate, differential diagnosis with the patient with Parinaud syndrome, of course, we're considering pineal region tumors, but you also want to make sure there's no evidence of strokes, hemorrhage. Maybe in the older population, multiple sclerosis can present with Parinaud's, AVMs, obstructive hydrocephalus, resulting in dilation of the third ventricle, trauma, and infection, particularly toxoplasmosis. Treatment is really aimed at addressing the underlying cause, and symptoms can be completely reversed in patients who have early hydrocephalus. So the aim is to, identify these patients urgently and treat them before permanent damage occurs. However, if there's persistent like upgaze palsies, they could potentially be corrected surgically, and there are some treatments for like visual training and tracking exercises or other options. So just to summarize, Parinaud syndrome is named after Henri Parinaud, who was like pioneer of the neuro-ophthalmology field. The classic triad includes upgaze palsy, convergence retraction nystagmus, and pupillary hyperreflexia. And while pineal region tumors are, the main culprit of Parinaud's and what we're discussing today, you want to keep in mind other broad differentials that we've discussed. And I just want to thank Dr. Klimo and Pete's section for inviting me to talk with you all tonight. And I really appreciate the opportunity. Thank you.
Kelly, that was great. I wanted Kelly to present Parinaud's because it's part of your preoperative discussion with the families and with the patient, what to expect after surgery. If you're working in the pineal gland, it's not uncommon that you're going to tickle or irritate the posterior commissure or that rostral interstitial nucleus of Cajal. So they're going to get a Parinaud. It invariably improves, may not completely improve, but it's just something I think families and patients, they should know about it going into surgery. It's just like, when you're doing the occipital interhemispheric, you should probably tell them that there's a chance that they may have some homonymous hemianopsia, or if you're doing the parietal interhemispheric, they may have some contralateral weakness, again, just retraction. But Parinaud's fascinating entity historically, and a very common finding after working in this area surgically. So thank you, Kelly. That was awesome. And I think we'll end it with Rabia's presentation, since we're now at just over 7:30. So Rabia, if you want to present your case.
Yes, sure. Let me see if I can. Can
And then
you
Toba,
guys,
I'll get to your question after Rabia finishes her presentation, if that's okay.
can
Sounds
you
great.
guys see my
Yep.
okay. All right. So I thank you first of all to Dr. Niazi, Dr. Leonard, Dr. Klimo for this opportunity. Really appreciate it. I am going to present a kid we saw in the earlier last year. So this was a 15-year-old girl who presented with 1 week of history of headaches, nausea, and vomiting. She, on further questioning, had been having these headaches for quite a few months. On examination, she had some cognitive processing delay, was a little slow, had the up-gaze palsy, and also had a right facial droop. My partner saw this head CT, placed a drain, an external ventricular drain. And then as you can see, I don't know if you guys can see my arrow, but there's a pineal region lesion here on the scan that we could see. Based on this, later I took her to the OR on her hospital day 4, did an external endoscopic third ventriculostomy and did a biopsy as well. After that, we tried to wean the drain off, but that could not happen while we were waiting for the biopsy to come back, and ended up placing a right frontal ventricular peritoneal shunt. On the imaging, I think the important thing in this case was that this was not only in the pineal region, this was actually expanding the aqueduct and also spanning the fourth ventricle. So the question was about the approach, whether or not we could try to get some part of it through the posterior fossa craniotomy and go through the fourth ventricle, or try to do a supracerebellar infratentorial approach. I initially tried to attempt that, thinking that since this lesion was below and anterior to the internal cerebral veins in the vein of Galen, that could be possible. The pathology came back as the papillary tumor of pineal region, grade 2. I took her to the OR. We did a posterior fossa craniotomy and tumor resection. Unfortunately, got the fourth ventricular part out. And you can see that there was a cyst, which was also, went away. However, some of this tumor got pushed into the posterior third ventricle. And thus the question was what to do. Well, after some discussion and with my colleagues, including Dr. Klimo, we decided to go the route of the transcallosal intravenous approach. And that turned out to be a really good way of approaching this, because as you can see, we got most of the tumor out. The veins were actually lateral and superior to the tumor, so that made it easy for us to go through that approach into between the veins. And we actually had a really good view of the aqueduct, and post-operatively, she did really well. There's still no recurrence. We also sent her for some proton beam therapy. 7-month post-operatively, she continues to do well. She has a shunt. She did develop some bilateral fourth nerve palsies after the radiation therapy. But the most recent ophthalmology exam did not show any diplopia, and she's been doing great. That's it.
Thank you. That was wonderful. Was there a unanimous consensus on post-operative radiation? I just wonder, with the grade 2 gross totally resected.
Well, the thing is, I know that there might have been a little bit tumor left behind on the veins, and that's why we decided to go for it, because the recurrence at 5 years is pretty high with these. So
Yeah,
that's
what
why,
Jason was saying.
yeah. So that's why we wanted to go for that.
It's a really nice approach. It's got a couple of intricacies and nuances that you have to kind of work through, finding the right inner hemispheric corridor, working around cortical veins. Toba asked before you started, what kind of complications, and I will say I have had venous congestion or venous strokes taking a cortical vein in that parietal area. It does give me pause. Sometimes you open up and it's just such a busy venous area there, and you're like, gosh darn it, where the heck am I going to find an avenue to get down? I would say I think kids are probably a little bit more forgiving in terms of venous rerouting than maybe adults. I think you can probably get away with taking a vein here or there in a kid more so than an adult, but I have been tagged and burned by taking a vein there. And venous strokes are totally different, obviously, than arterial strokes. It can be mild, just some congestion in the brain, and it goes away, and they have a good recovery. On the other extreme, it could be congestion, angry, hemorrhagic, and if you're in the parietal area, that can lead to a permanent deficit. They often get seizures. It's a very seizure-genic type of complication. So for me, if we're talking about complications, I'll say cortical, venous congestion, venous strokes is one that I've had.
Paul, I had a question for a tumor which is actually going to the fourth ventricle. Would you have tried to attempt it all with one? And
Yeah,
would
so
the
that's
transcallosal approach, or
Yeah, I mean, I think Guillermo talked about that in his presentation. So he makes a really good point. If there's a tongue of tumor going into the aqueduct, I think that's really hard to visualize that from an occipital inner hemispheric. I think it's really hard to get that part of the tumor from a supracerebellar. So I think if you have a significant amount of tumor that extends down into the fourth ventricle, coming from top down, I think is great. It is a long reach, but it actually, I mean, one of the coolest views I say to the residents and fellows is when you can see all the way down to Lushka and Magendie from the top. I mean, it's such an amazing view, but you can actually reach down there fairly well. So I probably would have started just from top and work my way down and see how much I get. I just simply can't reach the very bottom. Yeah, just do like what you did and come in from the posterior fossa. For the occipital inner hemispheric, my usual limitation is like if you find the parieto-occipital sulcus on that sagittal midline cut on the MRI, that angle is about kind of maximum for me to look down into the posterior fossa. It's kind of like just a kind of a guesstimation as to how far you can kind of angle down. But the occipital inner hemispheric does give you quite a good range in terms of superior view and inferior view. Any other comments or questions out there, Guillermo?
Paul, I agree 100%. Robbie, my only suggestion is, no suggestion, is I will have to start from the top, just because you never know if the tumor is soft, you can maybe get it out, everything from the top. Having said that, staging a really complex tumor like this one, I don't think it's the end of the world, and you provide the best possible outcome for the kids. So I think we're used to stage complex tumors, and I think the downside is very minimal. And in terms of complications, Dr. Niazzi, yeah, I had sinus thrombosis for one of the ICVs, but it did not happen in the first 24 hours. We got post-op MRI 24 hours later, and everything was patent. And 4 days later, the kid developed. It was a 3-month-old, so the age matter, I think. And the kid, as Paul pointed out, he had a seizure. That's the reason that prompted diagnosis of the thrombosis. But the kids are very forgiving and he recovered well, and with anticoagulation, yeah, everything resolved. So I'm always nervous, and I try to talk to anesthesia and ICU to keep the kids well hydrated, not just 24 hours, but for 2-3 days. I don't know if it does something, but well, I think we have one more question, Paul, if you want to.
Yeah, in terms, Amanda, I think, asked about staging. I couldn't agree with Guillermo more. Sometimes with these big tumors, do not be afraid to stage it. I mean, to try to get a one shot deal with some of these big tumors, it takes a lot out of you, and then you're getting longer and longer day in the OR, and you're starting to get fatigued. If it needs to be staged, absolutely, it's not a bad thing to think about that. In terms of when, in timing in between the stages, I don't know. I think it all depends on what the family wants to do and how the kid does from the first surgery. If they bounce back real quick, then I may do the second stage during the same hospitalization. If the family and the kid needs a little bit more time, send them home, bring them back. But I would usually do stages within probably 4 to 6 weeks. I don't think I would push it much more beyond like a month or so. If you're talking about something where you need to kind of get it all out, especially if something needs further adjuvant therapy. I don't like to kind of keep the train not moving, so to speak. I don't know. What do you guys think?
I agree, Paul. If I'm expecting a second stage, I try to do it within 48 hours. And sometimes I keep the kid intubated overnight, or at least have the possibility of doing that if it's a really complex tumor and you never know that you can get everything. But if not, I try to get it done the first week, unless, I mean, the kid has had a complication or a really rough postoperative course. Yeah.
Yes, I think we did this one maybe in a week or so, after a week of the first one.
I think the challenge with waiting too long is you get the fibrosis and you have a lot of reactive changes. That's what I've just noticed if we give it too long. So I agree with you, Paul and Guillermo, that it's difficult. I think it makes your more difficult, makes your job more hard. And it's more difficult to get things out in a safe fashion with all of that scarring and fibrosis.
Hi, my name is Rita. I'm a UMass resident at the University of Massachusetts. I'm a fifth-year resident. I was just wondering, have you also encountered venous hemorrhages from a infratentorial supracerebellar approach, and how do you know which veins are okay to take?
It's a great question. I almost never do the supracerebellar approach myself, but I mean, I think people kind of say, well, those precentral cerebellar veins are okay to take. I think my philosophy for veins is really try not to take any. Smaller if you have to, the smaller the better, but veins are just so unpredictable. I remember in residency once we did I think it was a trigeminal, a tick case, and we took one seemingly small vein, and it resulted in a pretty bad cerebellar, venous stroke, hemorrhage. It was just a nightmare. So again, I think you can get away with it more so in kids than adults, but I don't know what the other folks think.
Yeah, I don't know the right answer. The right answer, as Paul said, probably is just try to keep as many veins as you can. I try to go from one of the sides, not from midline. So I would never take both hemispheric veins. And if the tumor is really big, sometimes you have to take the central Birmingham vein, which is the one that is go from vein of Galen down to the vermis. I've taken it, whether I do at supracerebellar or a transcentorial. I haven't had an issue with that. but yeah, you never know.
Thank you.
It's interesting. I think Robbie on her presentation, I don't know if she can go back to it, but Walter Dandy was the one that first described the parietal interhemispheric transcallosal approach. He's got some beautiful diagrams if you go back to his original manuscript, and he actually purposely takes one of the internal cerebral veins. I mean, you can see the picture. He's got clips on either end of it. I mean, I wouldn't recommend that, but maybe you can get by with that. I don't know, but I certainly. I mean, there are some veins you just should not even consider taking. ICVs, maybe the basal vein of Rosenthal. Some of those precentral cerebellar veins that Guillermo's talking about. Those are probably more forgiving, but general philosophy: try not to take anything.
Thank you.
All right. Well, it is now 7:50 here, so this has been awesome. Thank you to all the people that I asked to give talks. I owe you big time, and I really appreciate everybody's participation. The questions were great. I hope this was informative. I hope it was useful. I know it was a little long-winded again, but I hope everybody got something out of it. And if anybody has any questions, you can always reach me or the speakers. I'd be happy to give out my cell phone or email to anybody who needs it.
Thank you, Paul. Thank you, Guillermo, Rubia, Jorge, and everybody that really participated tonight. Please stay tuned for our next session, which will be in about 4 to 6 weeks. And I'll send an email a little bit earlier than this time as to the date and the time. So thank you, everybody. Have a good night and happy holidays and happy new year to everybody.
Thank you.
Thank you, everyone. Thank you. Happy holidays.